Hey everybody, Dr. Michael Miyazaki again, and I am excited to be here with you. We have Dr. Ryan Walsh. And before we get to Dr. Walsh, let me do a quick intro because you deserve all the recognition that you need. Let's see, Dr. Walsh, you attend the University of Iowa, where you completed both your biology and dental degrees. Then you headed off to Texas A&M University College, where you got your specialty certificate in endodontics and a master's in the of science in oral biology. Now you're a certified diplomat of the American Board of Endodontics and an adjunct clinical professor at Texas A&M. And you've written and lectured all over internationally. And I will tell you, you lectured me today, so I wanted to make sure we recognized you and had you on the program.
Oh, thanks, Dr. Mike. I really appreciate the opportunity to be here. And yeah, let's talk some dentistry.
All right. So, what we're going to talk about is something that pertains both to the endodontic specialist and to the general dentist. So, if you're a general dentist and you go, oh, they're talking to an endodontist, don't worry. This endodontist is a really nice, cool guy. He understands what we as GPs are going through. And if you're an endodontist, don't worry. He knows how to talk to you too. But what we thought we'd talk to you about first is something that Vista Apex is just starting to release now. We've got a bioactive endosealer. We can talk about that briefly. It works really, really well. But we've got a bioactive endo putty. So I'm going to turn it over to you, Dr. Walsh. Tell us why we should be interested in both the sealer and the putty.
Yeah, I mean, I think bioactivity or bioceramics are certainly a buzzword in the endo world these days. As far as, we're no longer just filling holes, right? We're stimulating the body to heal and repair. And to me, those are two very, very different things. We now have the technology or we have the materials that we can put into a tooth and stimulate the tooth to form dentin and maintain a healthy pulp. I just saw the other day that there's materials coming out to regrow teeth. And, so I think we're a little ways away from that being predictable. But in the meantime, trying to maintain a healthy dentition and help people keep their teeth with healthy pulps longer into life. And if we have to do a root canal for the tooth, using a material that's stimulating the periapical tissues to heal, that's forming a good seal and preventing bacterial ingress. I mean, we have those at our fingertips. So to me, that's why I think some of these materials are the cutting edge and leading the good fight for maintaining our healthy teeth.
Yeah, no, I absolutely agree. I think in dentistry, things are changing. I think our patients are learning more about what dentistry can do for them. So they're really interested in preventing disease, or if there is disease, how to treat it minimally invasively. The conversation we had today was a great conversation. I think it's something that a lot of GPs run into, and then the endodontists after the GPs, and that is that you were talking about a patient that had a traumatic injury. So got hit in the mouth. The two centrals suffered pretty severe, large fractures, and there was a small pulp exposure. So um, it's a conundrum for the GP because a lot of times those patients will come to us because we're their regular dentist. So they're going to hit us first. Then we've got to figure out, can we treat that patient in our office or do we refer out to the endodontist because we have a small pulp exposure? So run us through that scenario, kind of explain that situation with the patient, give us some tips like the recipe that you would use on that patient. And then we had a great conversation of how do we then communicate to the patient so they have realistic expectations of what to expect long term.
Yeah. So going back to the case that we discussed today, exactly right. One of my patients was the lucky recipient of his brother's throwing a PlayStation controller at him and hit him in the mouth and chipped teeth numbers 8 and 9. And one had a very obvious pulp exposure, and the other was a very near pulp exposure. And so for a case like that, it had happened the night before, and I'm seeing him in my endo office the next day. You know, like you talked about, we know there's bacterial percolation from now the oral environment into the pulp. But the question is kind of like how much? How much is going to be impacted? And so the way I like to approach those, certainly I'm doing everything under rubber dam isolation. That kind of goes without saying, but uh, everything is under a rubber dam isolation and using a new diamond burr to just remove some of that contaminated, or I don't want to say infected, but uh, pulp tissue that was exposed to bacteria. So removing that superficial layer, and the underlying pulp tissue many times is very healthy. So if we can remove that pulp tissue, create a small little, I guess, access cavity or a
Mhm.
small little well, if you will, right over that pulp exposure, we can then irrigate the pulp with regular sodium hypochlorite. I mean, we're not injecting it into the pulp, but running it over the surface to get rid of any of that superficial bacteria. And as long as the pulp isn't bleeding, and as long as that patient isn't having, severe spontaneous, get kept me up all night pain, just a little localized sensitivity, that's a really nice case to consider doing a pulpotomy for. And so if we can keep that area clean, make sure the pulp tissue's looking healthy, we can place some, bioactive putty, regen putty right over that pulp space. We don't have to do any conditioning. You don't have to do anything special other than make sure that the pulp's clean and non-hemorrhagic. And you can just gently apply a little bit of that regen sealer, or excuse me, regen putty, and you just put it on a glass slab and roll it out just like you would IRM. These premixed putties behave very similar to IRM. They're just not as sticky. And so you can manipulate it, roll it into a small ball, and with your, IPC or with a plugger, you can just gently place it over that pulp exposure. Use a little wet cotton to kind of wipe the surface and wipe the dent and clean surrounding it. And you can bond right over top. So I think the IFUs technically say maybe place a small glass ionomer barrier over top of that, and that's just fine too. But we can place this bioactive putty right over the pulp, place a direct restoration that day. We don't have to wait for it to set. And then we just watch the magic happen. We watch that tertiary dentin formation right along that pulp exposure. And equally, we watch the periapical tissues to make sure that the root tips continue to develop and remain asymptomatic. And, I don't want to oversimplify things, but we also don't need to over dramatize it. That we can make pulpotomies or, pulp caps in a certain way, pretty predictable procedures.
Yeah, I know it's amazing. I mean, it's a great, like in this case, it was a young man. So by not doing a full-blown root canal, you're allowing the apex to develop, the root to finish developing, which I think is going to be super beneficial over the lifespan of that patient.
Exactly. Yeah.
What do you tell a patient? What are they to expect? Like in the next 24 to 48 hours, is there a little bit of sensitivity, or is it pretty much once the anesthesia is gone, they're going to be up and right again? Or are there any expectations you set up in the patient's mind?
You bet. I don't want to overpromise and underdeliver. So I tell mom and dad and the patient, but I always am conscientious to educate mom and dad about what to expect. That sensitivity for a couple weeks is okay. That's perfectly normal. I mean, even after a filling, you can have sensitivity for a couple weeks, as long as it's not all the time spontaneous. I just have a toothache to have a toothache. As long as it's not waking them at night, as long as it's manageable with, what you take for aches and pains, ibuprofen, Tylenol, many times that will just slowly go away as the pulp heals. So a little bit of sensitivity for a couple weeks, certainly with the trauma, a lot of times I'll tell them that, I think you've been through the worst of it. A lot of times they'll have lacerations or something that's been sutured. Like, hey, I think you're through the worst of the discomfort. Now, a little sensitivity for a couple weeks, maybe to hot and cold. If you get drinking water at school out of the fountain, yeah, it might be a little sensitive. But let's keep mom or dad informed that if it goes beyond that, let us know, because sure, we may have to do a root canal, but if we can allow these young teeth to grow and develop, doing a root canal down the road on a closed apex tooth is just much easier than doing it on a wide open apex, or one that's, let's just say it's 150 at the root tip. It's like those are just a little less predictable long term, and maybe the tooth's more susceptible to fracture. And your comment was very spot on earlier. It's like, let's try to allow more dentin thickness and increase the amount of tooth structure that's there to hopefully help prevent cracks and fractures down the road. So yeah, they may need a root canal down the road. The chance of them needing it's probably higher because these usually happen to young individuals, so they have time on their side. But that's all right. If we have to do a root canal down the road, but they still get to maintain their tooth, for most of their lifetime, if not their entire lifetime, it's like that. To me, that's a great service for our patients.
Yeah, and I think you're absolutely right. And so let me just kind of preface this too, because we're not saying that this is for every tooth. We were talking about it before. This was a traumatic injury. We knew that there was a small exposure, maybe a little bit of bacteria got into that area, but it probably, within 12 hours or 24 hours, you had been able to seal this up. Now, if it were a case with large decay, so a different type of scenario. So now you've got decay that's been in that area, maybe percolating through that small exposure that you saw as you excavated that area and cleaned out the decay. Would that still be a tooth that you would try to do this pulp cap with or indirect pulp cap with the putty?
So, I guess indirect pulp cap. I mean,
Pulp
maybe
cap,
it's
yeah.
semantics, but I'd prefer to do a pulpotomy. I think, our studies suggest, or at least have a track record showing that pulpotomies can be more predictable. Because again, I think a lot of times they're not done under ideal conditions, right? So if you're just in your general dental office and you have, cotton roll isolation and you're removing caries, um, it's like we know there's potential bacteria introduction there. So if you're doing it under a rubber dam, under the best case scenario, I think that'll um, lend itself to a better success. But again, if we're talking caries versus trauma, the way I like to approach it is, again, rubber dam isolation. I excavate almost all my caries except for the circumpulpal caries that are right over that pulp. So get everything else cleaned out. I use caries detect quite a bit to be sure that I'm not leaving something in a small little nook and cranny or up under some unsupported enamel, going back to dental
Hmm.
school days. But after that, then I switched to a brand new diamond burr and take that last bit of caries off that's right over the pulp and as I enter the pulp, because
Hmm.
I don't want to introduce more bacteria than is absolutely necessary. And in those cases, I'm removing more than just, a 1 or 2 millimeter layer of pulp. I'm probably removing, between 3 and 5 or 3 and 6 millimeters of pulp in that one spot. It really depends on what the pulp's looking like. Sometimes you get these deep caries teeth on a young person, and you get that pulp exposure, and if the pulp tissue just isn't very inflamed, it's like, well, that's fantastic. That's the best case scenario. And that if it's not very inflamed, well, if you remove about 3 millimeters of that pulp tissue to get any of the potentially infected pulp out, well, you can place your regen putty directly over that pulp and still expect a very predictable result long term. Now, again, I have to say this and at least preface, or at least go back and say that you have to have a good diagnosis, right? The tooth can't have irreversible pulpitis or symptomatic apical periodontitis, and you're like, well, maybe I'll just clean out a little bit and place it, and we'll hope for the best. In my experience, those usually go south pretty quick. But if
Yeah.
it's asymptomatic and it's a true carious exposure, as long as you have the right conditions, you can expose that pulp predictably. Again, I still use hypochlorite directly over the pulp. I use Chlor Extra, so 6% hypochlorite with surfactant directly over the pulp, and then to make sure you get a clean surface, and then your putty right over top, and then you can bond right back on that day, like right then. There's no contraindication to having to wait for it to set or go back and check it. Um, I think our materials are much more predictable than that these days.
Very cool. No, all great tips. Now we're going to switch hats. We're going to go from maybe the GP that's seen the pulp exposure, or we know we're close to pulp. We'll put our endodontist hat. It's going to be a little tighter, I think. So we're going to put an endodontist hat. So let's talk about the endo putty again. So you're an endodontist now. You're getting in there. Maybe you're repairing a root, or I don't know what you're doing, but tell us as an endodontist where you find the benefits of the endoputty.
Yeah, truthfully, it's the same indications we talked about plus, right? And what I mean by that is, I'm still doing pulpotomies for young people. Vital pulp therapy is fantastic. Again, they might need a root canal down the road, but if we can predictably do it now, why not maintain that pulp? But other things we're using it for, we're using it for apicoectomies. I mean, you can use this putty exactly how you used MTA in the past. The difference being that it's a pre-mixed material. Like I said before, it behaves like IRM, so you can roll it into a little ball or a little. We roll them into hot dogs out on our glass slabs, and then take little increments to pack at the root tip. You handle that very much the same. We can use it for resorption repairs. If we have an internal perforation, they're beautiful for that, especially anything subcrestal, right? One of the
Mhm.
tips that I would pass along is that whether you're an endodontist or a general dentist, these materials are, by and large, aren't really aimed at being exposed to the oral environment, like a direct dental restoration, like composite. They're meant to be internal to the tooth or subcrestal. So if you have a subcrestal perforation, great. This is the material we should be using because it promotes hard tissue formation exceedingly well.
Yeah.
Um, for something above the bone or exposed to the oral environment, we need to pivot materials altogether. But using these putties for pulpotomies, for perforation, for resorption repairs, for apicoectomies, I mean, as an endodontist, having this in my toolkit's pretty important part of the arsenal that we need to have at our disposal.
Yeah, very cool. And one last question is, we talked about, and we're not naming names, but there's other similar products out there that, say they're good for indirect or direct pulp caps and things like that, but you light cure them and they set. What's your feeling about those types of products?
Ah, those are not products that I use or incorporate into my office, because, like we talked about before, the claims are very promising, right? They're promising all this bioactivity, and they're promising that, hey, it's going to help the pulp. But the fact of the matter is that's not the case. And the reason being is that if you have to light cure something, it has resin. Well, if you have a bioceramic or a bioactive material encased in the resin matrix, it can't be exposed, right? And what I mean very specifically is that these, like regen sealer and regen putty, they need moisture to set. So they take the moisture from the dentin tubules or from the surrounding apical tissues, and they use that to set hard like cement. So if you're doing a pulp cap or a pulpotomy, you're using that moisture from the pulp to set that material and the surrounding
Mhm.
dentin.
Yeah.
So these resin-based materials, completely different. If you trap those bioactive particles inside a resin, they can't absorb any of the moisture, nor can they release any of their byproducts that stimulate hard tissue formation. So although they claim to be uh, MTA based or have other types of bioactive material, they may have it in the material, but it's not active. So you're basically
Mhm.
getting 0% bioactivity with these materials. In addition, you're putting resin directly over vital pulp tissue, and we know from many past studies that's very cytotoxic for that pulp. So the chance of the pulp having a long-term predictable result just starts decreasing rapidly. So they have a lower active bio, they have lower content of bioactive cement that's not even available to the oral environment. So for me, those are an all marketing ploy and no actual biological or physiological activity.
Yeah, no, just not as predictable. I think those are great. Everything that you mentioned during this interview, and I think the best thing about this is it's not just me; it's the two of us. So I really appreciate you for being here. But I mean, great tips. So if we're in a situation like this, we want to make sure we isolate the area, use of a rubber dam, just so we don't contaminate the wound even more. Like as you said, as you get closer to the pulp, you're going to go to a clean diamond, sterile diamond again, to so we don't inoculate the pulp with more bacteria yet. We want to use a material like the bioactive endo putty from Vista Apex to place that over that exposure. We could remove a little bit of the pulp tissue, and as long as the bleeding is controlled, we put a little bit of that putty there. And it's not going to completely set. We're not going to light cure it or anything like that, but we can go ahead and bond a restoration over that and seal that area up to protect it. And it's going to heal up fine. Hopefully, as you mentioned, we'll get that tertiary dentin formation underneath our putty. And if we can do that, then many times we're going to get away without having to do a root canal. But I think it's always important to explain to the patient that maybe a root canal is going to be needed down the line. I mean, that tooth has been
Yeah,
injured pretty severely. So, we'll keep an eye on that. But if we've got a young, especially a young patient, as you're mentioning, and during that time, the root can form more, the apex can form more, by the time we get to the point where maybe we need to consider a root canal, I think the tooth's going to just be a better tooth to perform that procedure on. So, no,
exactly.
great tips. As you can tell, I took a lot away from our conversation. So, thank you very
I can
much.
I can tell you were taking notes. Awesome.
Yeah, I was. They're all over here. No, it's great. Okay, well, one more thing we want to just announce is October 3rd. Again, there's going to be an endodontic conference uh, talking about the latest and greatest. So there's going to probably be some information attached to this below. So check that out. You can get a discount if you use the code that you'll see below. And we hope to see a lot of people there. Yeah, thank you very much, Dr. Walsh. It was great talking with you.
Appreciate it. And thanks again for having me on. And October 3rd, Dr. Justin Kolnick, that's one that shouldn't be missed. Looking forward to it.
Yeah, yeah, cool. Thank you.
Bye.
Take care, everybody.